Good morning to you all. Curtains are being raised for the 51st Annual Conference of the Association of Otolaryngologists of India, West Bengal, with focus on New Age ENT. ENT that you knew in the 1990s is not the ENT of the 21st century. Let us begin the conference by listening to the views of the stars of the contemporary otolaryngology. The chairpersons of this symposium are Dr. Manjula Bhattacharya De, Dr. P.B. Rai, and Dr. Subhajit Banerjee. Please come to the stage. The session will be moderated by me. Our speakers are Dr. Animesh Ghosh, Dr. Soikat Samaddar, Dr. Rahul Sarkar, and Dr. Rajiv Singh. As we know, ENT is expanding both horizontally and vertically. Over the last 40 years, the specialty has undergone dramatic developments and has taken advantages of the advances in endoscopy, microsurgery, lasers, reconstruction, and microchip technology. During this period, some otorhinolaryngologists, although still calling themselves ENT surgeons, have subspecialized in otology, otoneurology, skull-base surgery, head and neck surgery, phonosurgery, rhinology, facial plastic surgery, and pediatric otorhinolaryngology. Dr. Animesh Ghosh is such an ENT surgeon who has established himself as a head and neck surgeon. He is presently the associate professor in the Department of Head and Neck Surgery in IPJMER SSKM Hospital. I invite Dr. Ghosh to speak on super specialties in a specialty. Dr. Ghosh, please.
A very good morning to the respected chairperson, my teachers, and my seniors and friends. Let's have a look at this picture. This is a picture of a duck with ducklings. But if we mix little bit of our imagination related to ENT, we can see this is a mother ENT along with her kids. By name, they are known as otology, laryngology, head neck surgery, phonosurgery, and all this. Let's see what happened to them with the age or with the time. Wow, they are growing, they are swimming, they are happily lead their life together. Now they become adult. And you know what they wants to say something that we are adult now, we are independent now, and we want to lead our life with our own identity. So, if the grows or develops or flourish, they will be independent and appear with their own identity. And this is a natural process. No one can stop this. So, today my topic is super specialty in specialty. I am Dr. Animesh Ghosh, Associate Professor, Department of Head and Neck Surgery, IPGMR. Now, the question is, why super specialty? Is it necessity in this dire time, or its desire? Let's have a tour through the medical field to know what are the changes occurs in this field. Doctor's image to the society. Now look at this picture. The middle one with the white hair, who is he? He is none other than Dr. Ogneshwar Mukherjee. I know that I have taken this picture from the movie of Ogneshwar and the role played by Mohanayak Uttam Kumar. But what he created an image of a doctor, ideal doctor that stuck in our mind, compassionate and careless about his own lifestyle and wants to help or treat each and every kind of patient. Now look at the new age of the doctor, very sharp, mind-wise, look-wise. They want to focus themselves with a specific object and want to do that passionately. Little bit of anger and speed is also there if you look at this picture carefully. So, what are the changes occurs from Ogneshwar to Kabir Singh, from Jack of all to master of one, From doctor decision to patient decision, yeah, that is also important. You know, in our time, we used to treat the patient with our own decision, but nowadays we know we have to offer different kind of modalities to the patient, and patient will take the decision. That is the thing that changed in our mind from recent past to now. Now look about the patient's relative attitude. Again, the picture I have taken from the movie Agnisar. Look at the gesture of the patient, how he is talking with the doctor. Now look, the recent age. This patient is asking why. The surgeon wants to say something that this kind of complication may occur after the surgery. I will try my best to give you the best result, but I can't give you the guarantee, and the patient is asking why you can't do this, why you can't do the surgery without any complication, why, then how are your doctor, and like that. And the second picture is very distressing, you know, this vandalism. Yeah, I know that it's not the whole scenario of this recent, but this kind of action are increased in such extent that I can't ignore it. So, what are the changes occur in the level of patient party's perception? Loss of patience, respect, trust to the doctor, develop anger, frustration, and unrealistic expectation. And obviously, I must mention that they are influenced by Dr. Google, and we face this kind of problem. Okay. Now, related to administration. In our time, there was only Medical Council of India and WB Medical Council. The name has changed, and they came as a NMC. But don't think this is a old wine in new bottle, because they are doing something. They want to change the concept of the teaching, learning, and all these things. So they are doing some action in this medical administration. So it's very important to know that NMC action, and you know, in our time we want to be after passing the MBBS, we want to be a doctor like who can treat every kind of patient, a little bit of surgery that we want to do also. I mean, jack of all types. But you know, the definition given by the NMC, the MBBS doctor should be physician of first contact of the community while being globally relevant. And they are trying to fix the duties of PGTs and PDTs. And I will not be surprised if they fix the field of work of specialist doctor and the super specialist doctor. Okay? And medical treatment regulation committee and authority, they want to regulate our treatment plan and want to judge our treatment. We have to respect them. And the third one is Consumer Protection Act. And now this medical service is a product, and the patient are patient party and patient are consumer. If they are not satisfied with the product, they can sue us. So we have to remember all these things. Now, in terms of ENT, you know, if you look at the title of the books from recent past to now, you see the changes or the evolution that occur in the title of the book also. From the general surgery to ENT, and from ENT to ENT and head neck surgery, and from ENT head neck surgery to the book of otology, rhinology, rhinoplasty, facial plastic surgery, head neck surgery, and all this. So if you look at this, and you can feel that ENT now become as a giant, and we have to accept this. And let's have some clinical scenario from the hypothetical world to the scientific world. You know, this is a patient presented with a thyroid swelling, and we did a USG that reveals 2 centimeter thyroid nodule with thyroid 3. So what we should do next? We should do FNAC or not? There is a little confusion. You can do whatever you want to do, there is no problem. But if you really want to follow the international guideline ATA, then the follow-up will be sufficient to this patient, as the size is 2 centimeter and the thyroid is 3. Now this, in the second case, as I am from the Department of Head Neck Surgery, that's why I am showing these slides. Biopsy reveals squamous cell carcinoma, and radiologically there is no bony involvement. Now the question is whether we need to do the mandibulectomy during the time of excision of this mass or not. Yes, we need to do the mandibulectomy, because we need to address the third dimension of the cancer or the tumor, properly, we have to do mandibulectomy also. Now think about the situation. I mean, a patient lady undergone chemotherapy for the stage 4 ovarian cancer along with lymph node, peritoneal lymph node. And after that, as a routine follow-up, we did a PET CT scan. They did the PET CT scan that reveals focal uptake at thyroid level. And then we did the FNAC, and that reveals papillary carcinoma of thyroid. Then what will be the next step? Should we jump over the thyroid and do thyroidectomy as because there is a papillary carcinoma of thyroid? It's not. You have to address the life expectancy of that patient. If the life expectancy is 6 months or 1 year, then why should I go for surgery? So it is better to treat the patient, not the disease. Now look at the CT scan picture. This is a picture of a squamous cell carcinoma, buccal squamous cell carcinoma involving the ITF. Pterygoid plate is also involved. Now, is it resectable? Yes, it is resectable, but it's not operable. So these are the changes occurs in the field of ENT. Now we have to be highly skilled to keep up with the increasing demand of the patient, and we have to be very precise to achieve best outcome and avoid complication as less as possible. And we should follow the international standard guidelines, should offer treatment to avoid CPA and all this. Okay, I fixed this picture to say one thing, that if you really want to do some work precisely, your field of work will automatically reduced or restricted. That's why I've shown this picture. Now look at this new age of ENT doctors. Sayan, Arindam and Mridul is there. They love to call themselves as a otologists. They are focused on the otology. And this man is so thick, and he want to establish himself as a rhinoplasty surgeon as well as ENT surgeon. Okay, I have shown this picture as because I know them very well. They are my friend. I'm not saying that they are the only person who doing this. We have so many others in our ENT armamentarium. Just because I know them, I post their picture, and I do not need to take permission from them. As all of you know, MCH head and neck surgery already started in our institute, IPG MER. And I must utter the name of one person behind in this aspect. He is none other than Professor Arunabh Sengupta. NMC is thinking to start plastic surgery and neurosurgery, MCH, from the field of MSENT. And who knows that we will see one day that MCH in otology. This is my last slide. These three pictures are showing same object, but the views are different as the viewers are different. First one from physician's view, second one is specialist view, and the third one is from super specialist view. Thank you all.
We move on to the next speaker. Training of the budding ENT doctors must also match the expanding vastness of the subject. Dr. Soikat Samaddar, Assistant Professor at the Institute of Otolaryngology, IPGMA SSKM Hospital, will speak on the need of training in this specialty for this new age.
In my short journey till date, I have come across my teachers who have played a very pivotal role in shaping my present and my future. So today if I have seen any further, it is because I am standing on the shoulder of these giants. And with this note, I would like to thank the chairperson, my teacher Somen Banerjee sir, the panelists, the delegates, the esteemed delegates, and AOY for letting me present the art and science of new age ENT training. I will begin with a very small demonstration. If you can look over here. What I will do is, I would like to fill up this bottle with a bit of water. Oh, sorry, I forgot to open the cap of this bottle. Sorry. Now let me feel. If I do it very fast, the water might spill. So a gentle, gradual feel is what is needed to fill this bottle up. Let's see what it means to us. So opening the cap of the bottle is the first, foremost, and the most important step in the entire training process. And this has to be followed by gentle pouring. And this is the main philosophy behind new age ENT training in the undergraduate level. In the undergraduate level, we are dealing with adults who have their intrinsic motivation and their knowledge is problem-centered. We will only encourage and nurture their learning. So conversion of an empty classroom to a field lecture theater requires opening the cap of the bottle. And this can be done by grouping the students into small entities and giving them mini projects or tasks. I have given an example over here. Documentation of ear care practice in a community is one which I once gave a few students. And what this led to is that the students got self-motivated, they diagnosed what they need to learn, and they were interested in coming for the lectures. So new age training is about encouraging students to find out what they need. This is followed by gentle pouring. Gentle pouring is the teaching learning method that we practice as of now. In comparison to the traditional teaching, the present day teaching in undergraduate and postgraduate level is competency based. What is competency based can be summarized through this small example. As you can see over here, these are a few competencies that our National Medical Commission has already standardized. First one is demonstration of the correct technique to perform and interpret pure tone audiogram and impedance audiometry. Second one, choose correctly and interpret radiological, microbiological and histological investigations relevant to ENT disorders. So these competencies are very specific. They have measurable dimensions of knowledge, skill and attitude of the learner that it harps upon. It de-emphasizes on time and makes the learning more of a learner-centered learning process. These competencies do strike a few important domains of learning. That is the cognitive domain or the knowledge domain of learning, the psychomotor domain or the skill domain of learning, and the affective domain or the attitude domain of learning. If we find it difficult, let us decipher it through some examples. If I teach or make a student learn about the pathophysiology and clinical features of otosclerosis, I am striking his knowledge domain only. But when I ask the student or when I demonstrate before the student to perform a tuning fork test in this patient in a simulated environment, this strikes the skill domain. And when this patient and when the student is asked to counsel a patient regarding the candidacy of stapes surgery, this is the attitude domain of the student that we are dealing with. The tools that we use to impart all these teaching learning method are very basic. This ranges from small group discussions, large group discussions, to skill labs, OPDs, IPDs, and operating rooms. I will discuss more about skill lab in later part of this discussion. Assessment of the students are a continuous process where we assess what the student knows and knows how to do it. He shows and he has a basic knowledge about his attitude, ethics, and communication skills. This is a theory paper from phase 2 MBBS exam in the new regulation NMC guidelines. As we can see in questions 1A and 1B, this is a problem question where it has been categorized or structured. So the long questions are gone and are replaced by long structured questions where the marks are divided into short segments, short entities. The one other interesting thing in this question paper is what is in number 3. I have highlighted it in blue. Here the student has been asked or the learner has been asked, how would you counsel a patient who has presented with a white patch in the oral mucosa to quit chewing tobacco? Now this type of questions has been made mandatory by the National Medical Commission, and one such question, at least one such question should appear in the question paper, and this affects or strikes the attitude domain of the student's learning process. These reasoning questions are followed by MCQs. The MCQ assesses the knowledge domain of the students. So we mourn the death of a long essay type question that we used to have previously. This is followed by the practical exam, which is now called an objective structured clinical examination exam, where students are given very interesting cards, role plays are done, simulated environments are given before the students where we can assess their attitude, ethics, communication, their skills. And wherever there is art of medicine, wherever the art of medicine is loved, there is also a love for humanity. And we need to love humanity and put it inside the new learner. We have been producing highly skilled physicians, but now it's time that we produce highly professional doctors. This brought forward the attitude, ethics and communication module, which has been made mandatory in the entire teaching process in the undergraduate and postgraduate level. Examples like obtaining informed consent in simulated environment, dealing with angry family members, this strikes the attitude, ethics and communication modules. Now the doctors that come or the Indian medical graduates are more competent and are more professional. The second part of the demonstration is similar to charging your mobile phone. The first 50% of the charge takes place very easily, but the next 50% and going up to 100% do take time. And similar is filling up the bottle. If I fill very fast, it might spill. So I need to fill very gradually, and I need to check whether my filling is appropriate or not. So gentle gradual filling is the motto or philosophy of new age ENT teaching at postgraduate level. The teaching learning method is similar to that of the undergraduate level, where we have small group discussions, but these discussions are more of problem case discussions, student-led group, self-help group, buzz group, crossover, mini projects and role play. Rotations in super specialty units should take place. Rotation in super specialty ENT unit, head neck unit, plastic surgery, radiation oncology. The district residential program has already come into place in our state, and students or postgraduates are going for this program where they are serving the community. Clinical meetings are very important. Logbooks helps quantify what has to be done. This is a photograph, or this is an extract from a logbook. As you can see on the extreme left, the competencies are mentioned. Next, how these competencies are to be obtained is mentioned, that is in the form of tutorial in this place. The interesting thing is the segment 8 or the column 8, where a feedback has to be received from the learner or the students by the teacher. It is not only the teachers who are assessing the students, but the learner should also give a valid feedback to the teachers. We are very thankful to Aishan sir and his colleagues who has prepared this logbook so diligently for the undergraduate level, and we look forward to receiving a similar logbook for the postgraduate level, which is still now not existing. Demonstrate, observe, assess and practice, perform can be done in OPDs, IPDs, operating room and skill labs. Unlike the previous times when we used to learn by operating on live patients, now we operate in highly skilled dissection rooms and skill labs, which constitute mannequins on which the doctors can first perform, assess themselves and go forward before doing an exact procedure on the live patients. 3D printed cadavers, these are 3D printed temporal bones. This is available in India as of now. IMUST, which is an organization in Bombay, they are giving 3D printed cadavers of head, neck, nose, paranasal sinuses and ear, and they hold regular fellowships round the year. This is a virtual dissection table, and this type of dissection table is available in RGCOR also. So skill labs recreate the clinical environment and tasks which future healthcare workers have to perform with various level of complexity and fidelity. It enhances, it enhances our clinical, motor and communication skill, as well as helps us build up our teamwork. Research work, one of the important aspects, and now National Medical Commission along with ICMR and National Institute of Epidemiology has built up a biomedical research curriculum, and it has become mandatory for the students or the learners as well as for the facilitators or the teachers. This is followed by synopsis writing, thesis work, and of course, publication in peer-reviewed journals. The next 5 things are not mandatory as in NMC, but I think these things are very important for a budding postgraduate. Networking is very important, where they mix with their peers, their seniors and the juniors. Communication, teaching at the undergraduate level, having a basic knowledge of the hardware they are operating, like the endoscopes, the microscopes, the debriders, and all other instruments, and they should have a basic knowledge about the softwares, which not only includes the softwares running those hardwares, but also softwares like DICOM, which is a radiology software, and SPSS, which is a statistical software. Assessment again over here is a continuous process, and one thing which is missing over in our curriculum is an appraisal process. Appraisal is an annual assessment process facilitated by self-reviews, supported by feedbacks from colleagues and other supporting healthcare workers, patients, case reviews, and review of the clinical skills. And following post-graduation, we have to be lifelong learners, and I could not find a more befitting photograph of the spirit of a lifelong learner than this. Learners has to do good networking, acquire new competencies, embrace new domains. They have to be good trainers, and they have to balance. Embracing new domains of the expanding horizon, new technology via skill development workshops and fellowship is very important. The career development does take place in the skill development workshop, and one has to establish oneself in larger platform, and this is a very important aspect for lifelong learning. Training to balance life is the most difficult part in the entire training process. The formal session regarding the same is very much the need of the hour. And all this is needed because we need to address the diverse ENT care needs of the diversely growing population that we cater. Thank you so much.
The teaching learning method prepares the new generation ENT surgeon to tackle the new world. Dr. Rahul Sarkar is in the corporate healthcare setup. He will stress upon the needs to modify the attitude of the doctor to make the best use of the modern developments. Dr. Rahul Sarkar, please.
My respected teachers and seniors and my dear colleagues. Today I'll talk about the topic back to the basics. I'll start with the picture of my alma mater, RG Kor Medical College, where I did both my MBBS and MS. And then I spent 6 glorious years in the prestigious Institute of Medical College, Kolkata. I am practicing since 2015, and this little 8 years of experience, what I have learned that the tip of the iceberg phenomena is actually true. That is, the rare diseases are actually very rare. What is the context? The context is our mother subject ENT is expanding like anything. Today we have head neck surgery, skull base leading to anterior and lateral skull base, facial plastics, rhinoplasty, implantation and everything. But what we do need to understand that for every super specialist ENT surgeon that Animesh talked about, there are at least 100 specialist ENT surgeons who are doing their regular basic ENT practice. I remember as a PGT, I used to read this book on recent advances by Dr. Lalwani. It was very fascinating to read this book, new ideas, new thing. But coming to the practice, that I have understood that these are very randomly or very rarely that you do these things, and what you regularly do, that is the basic ENT practice. And what we need to emphasize that with the advent of new technologies, new thing and new understanding of the subject, we need to strengthen our basic ENT practice. Let me give you some example. I'll start with the very basic wax removal. This is a very initial thing that we learn in our career, and this thing is often entitled to the junior most PGTs and even the house staffs and interns. There is often incomplete removal, there is injury leading to pain and bleeding and all. But what we fail to realize that many of these patients are actually suffering from keratosis obturans, and which is extremely difficult to remove. So what if we introduce a very little change, if we introduce a microscope in our daily practice, and if we do this thing, suction clearance under microscopic control, we have to understand that it's actually a time-taking procedure. it may take up to 15, 20, even 30 minutes to clean a very deep impacted works or a keratosis obturans. But one thing we have to understand, as a surgeon, we might think that these are trivial things. A big surgery is a very beneficial thing for a patient, but if you think from a patient's perspective, the satisfaction level, even after such a procedure, is extremely the same as a good surgery. I'll try to give an example. I'll talk about Dr. Vikas Agarwal. Sir has come to many times here in Kolkata, and I've seen in Sir's clinic, many high-end patients come to his clinic, and it takes about, say, 20 minutes to 30 minutes to do these procedures under microscope. And what he charges over there, many of the new age ENT surgeons sitting over here, we do not get that remuneration even after doing a tympanoplasty. So the idea is there should be no pain, there should be complete removal, there should be no bleeding, and when patient leaves your clinic, the patient should leave with a smiling face. So what are the other aspects where we can introduce this microscope in our routine practice, like thyroid surgery? The concept is growing. The initial thought process was the focus was on recurrent laryngeal nerve. But nowadays, we are more and more understanding that it's extremely crucial to save the parathyroids, not the glands only, but also their vascular supply, and also external branch of superior laryngeal nerve, particularly in case of singers and other professional voice users. So these are the cases where we can easily use a microscope and improve our skill. Similarly, in case of parotid, dissecting the tumors on the facial nerve. Yes, in Western countries or high-end centers, even 3D exoscopes now are available. But again, talking about the routine daily practice, simple addition of a microscope can do wonders in certain cases. In our training period, we have traditionally learned that microscope is for ear cases, endoscope is for nasal cases, but that boundary is already gone. And otoendoscopes has made it advances in the field of otology. We all know about endoscopic steppies or use of endoscopes in mastoid surgery to look around the corner to limit the dissection. But another important aspect is that with this improved visualization, the understanding of the anatomy has gone a sea change. We have learned the anatomy much better with the endoscopes. And if we talk about introducing these little changes in our daily practice, in clinical practice, if we can show the patient what the pathology the patient actually has, the patient becomes more aware about their disease process, and they are also part of the decision making. Nowadays, the practice is not like that. You can just say that you have this and you have to undergo this surgery. You have to explain them everything, and patient is also part of the disease process. At one hand, it actually increases the case conversion rate, but another hand, post-op also, you need to show patient everything, and gone are those days when you can simply claim the surgery is successful. It's no more like that. And this kind of demonstration to patients, these actually do not require any fancy instruments. So you can simply use a Bluetooth endoscopes kind of thing, and you can show the pictures and everything in your mobile only. Regarding the imaging, the new age ENT surgeons, they read their own plates. You have to learn to read your own plates, be it a USG for thyroid, CT scan for nose, PNS or temporal bone, or MRI for CP angle or maybe PNS. So you need to read your own plates. This not only gives you the surgical landmarks, but again, like endoscope, the understanding of anatomy becomes much more better if we can learn to read the imaging plates. Also, this gives us a lot of physiological understanding as well. If we look at the left-hand side of the picture, there is this selective attic cholesteatoma, where the mesotympanum is completely clean. So this gives us the idea of the selective attic ventilation pathways that we read in our textbook. This kind of images reinforces our understanding of physiology. And the picture on the right-hand side, this is a 4-year post-op follow-up of a type 3 tympanoplasty. The patient's hearing, post-op hearing is extremely good. And if you can look carefully at the picture, it's a type 3 tympanoplasty. A TORP has been placed over the oval window. If you look at the TORP is sitting right at a 90-degree angle. There is adequate middle ear air space, and there is a sliver of cartilage lying right on the top of the TORP. So these are the things that you need to understand what makes a good hearing. So this understanding of this anatomy and physiology has become more and more important to deliver better care to our patients. Talking about a little different thing, vertigo is a very common clinical scenario that we face in our day-to-day practice. And understanding that most of these vertigo cases are peripheral and even BPPV are much more common, we have gone beyond just prescribing some anti-vertigo drugs. Nowadays, Dixolpike and Macleopagnini are part of our routine checkup. And more ENT surgeons are now performing these maneuvers like Epley's. Some prefer, of course, Simont maneuver, and for geotropic BPV, we have Guffoni, or apogeotropic lateral canal, we have Appiani. And even for rare cases of anterior canal, we can go for Iacovino as well. Now, the thing is, what we need to stress upon is that ENG is more and more being replaced by video nystagmography nowadays, because nystagmus is a crucial thing to understand all these pathologies, and VNG is a simple thing we can do in a very simple setup, and understanding the nystagmus has improved our knowledge and management of these positional vertigos. Another upcoming thing is about allergy. It's again a very, very common scenario, and even in this seminar, we have 2 talks on this topic. And again, it is a very simple procedure. You do not require any fancy thing. You can simply do a skin prick allergy profile and go for desensitization. And over our experience of last 3 to 4 years, around 75 to 80% of patients, they are doing actually quite well with this desensitization therapy. Chronic cough, another very important and frustrating presentation to our ENT surgeons in our clinic. We know all the enlisted things in our textbooks, but we have to understand one thing, especially after COVID, this chronic cough has increased a lot, and most of them has been diagnosed as post-viral vagal neuropathy. We need to understand the physiology, and this understanding has led introduction of drugs like amitriptyline in a lot more way, and that is causing a much more improvement in this kind of patients. And differentiating them from reflux and other causes, it takes a simple FOL, nothing else. As also been discussed by Dr. Shomadar, the new age ENT surgeons has to be much more what should I say? They should be much more confident about using different softwares. This is the need of the day. The different investigation softwares are there. You need to present in different talks. So there are different video and photo editing softwares and data management and hospital management softwares. So you need to understand and operate all these kind of softwares, which you know it was not that much earlier needed, but this is need of the hour. Certain other things, we need to understand health insurance. This is becoming more and more important. These are some certain things that you are not taught in your medical school, but you need to understand. Nowadays, there are n number of insurance companies, n number of TPS, there are n numbers of their permutation and combinations. There are certain package case and open case. In our training, we are taught that open case means open surgeries, like open cholecystectomy, or you have laparoscopic surgeries. But now we need to understand there are certain open case, open package, and package case. So these are different things. And balancing between this science and commerce, this is also the need of the hour of the new age ENT surgeons. We are constantly under surveillance, be it in CCTV, be it under recording. Every patient you call, whenever you call them, or the patient calls you, they turn on the recording button. So whatever you are doing, whatever you are saying, you are monitored and you are recorded everything. So it's like performing under constant surveillance. So even under this surveillance, not only you need to perform well, but also you need to promote yourself. So that is again another need of the hour. There are plenty of social medias. Earlier it was like you work hard and let your success make all the noise. Now the thing is, even if you work 50, you need to promote yourself 100%. And now the system is review based. People come and review you. You have to have your online presence, digital marketing, and even some of the new age ENT surgeons, they are allured to buy fake reviews by making payment. So these are the changes that we are going nowadays. And all this comes at a cost. Setting up a ENT clinic, ENT is not an inexpensive thing to set up. There are new age instruments, you need to do all those marketing and everything, and at the same time, you need to learn and understand the advancement of your subjects. So managing all the things is the crux of the new age ENT practice, and irrespective of all the things, with the advent of new thing, the ENT, our mother subject, otorhinolaryngology, is bound to proceed further and further. Thank you.
Thank you, Dr. Sarkar. Now, Dr. Rajiv Singh, Assistant Professor, KPC Medical College, will now sum up the advances in otorhinolaryngology and speak on the dynamics of the new age ENT care. Dr. Rajiv Singh, please.
Good morning, everyone. Welcome to the 51st Annual Conference AOIWB. And I am Dr. Rajiv Singh and will be speaking on the last topic of the symposium, experience of the new generation ENT head neck surgeon. And I'll be sharing my views on the dynamic of new age ENT care. So when we actually talk about ENT, just like any other living things, ENT is also growing, and not only organizationally, it is growing in terms of the subject as well. It is one of the most sought after subject in the world, and with the renewed interest, there has been increasing trend of accepting ENT in postgraduate in India as well. So ENT, just like a fully grown tree, it has branches. So similarly, ENT is also having some well-grown branches, and each of the branches actually is capable of providing the satisfaction and success when actually excelled in properly. The various branches that ENT is having is otology, rhinology, laryngology, and plastic and the neurosurgery. So we will be taking each branch and we'll be trying to understand by analyzing the surgical growth that each of the branches has undergone in the last few decades, which will help us in understanding the dynamics even better. So when we talk about the basic surgery in otology, that is the tympanoplasty. So nowadays we have a tympanoplasty where the surgeons are aiming at a success of around about 95%, even more than that. Because in maybe 2 or 3 decades back, the story wasn't that. Because of the non-availability of the resources, maybe the operating microscope wasn't up to the mark, the instruments weren't that good like the one we are having. We didn't have the detailed anatomical details which is so vivid with the endoscope nowadays. And the surgeries are being done in remote area with microscope and even endoscope with success as high as 90 and 95%. So that is what has actually changed in the recent past. Same goes with the mastectomy as well. The mastoid surgery, which earlier had comes with a lot of complication, that actually also made ENT surgeon bit fear about the complication that are related with the mastectomy, with the weeping mastoid, with the advancement of the technique and the newer advancement in the microscope together with the endoscopes that we have, the success rate has improved leaps and bounds in the decade or so. Same goes with the stapedotomy. Once, because of the technical difficulties, it was considered to be the surgery of the elites, but right now it is being wielded by most of the surgeons all over the state because of the advent of laser, the advanced microscope, and also the endoscope. As has already been mentioned by Dr. Rahul, that endoscope is nowadays one of the most used instrument in otology as well. That has improved the patient satisfaction and the success rate overall. Coming to rhinology, so the basic surgery that generally one relates when we talk about rhinology is FES. So it has also undergone a drastic change. If we talk about plucking of the polyp, which was done maybe 2 decades back. It has changed to the surgery where even few millimeters of nasal mucosa is being protected in order to have a healthy outcome in the first surgery. And it has only been possible because of the high-end resolution endoscope with the HD cameras that we are having, and the microdebrider and the other powered instruments that we are having at our disposal. Not only FES, we can do even certain procedures which are going beyond the nasal cavity. We are doing orbital decompression. We are doing endoscopic DCR, which was once considered to be the domain of the ophthalmology. And we are doing it with great and excellent results as well. And not only in the benign diseases, even the skull-based tumors, where the tumor is involving the nasal cavity and extending up to the skull base, those tumors, if properly assessed, can be easily removed with the endoscopic approach using coblators, the neuromonitors, nerve monitors that we have, microdebriders, the Dopplers, and the other instruments that we have at our disposal. Though the next branch is laryngology. Phonosurgery has also seen a lot of advancement because of the advent of the laser and also addition of the HD camera and the endoscopes that are now being used for doing the phonosurgeries, which has improved the complication and also the success rate in terms of the patient satisfaction and the surgeons as well. We also see a lot of changes in the head neck cancer, where more and more conservative surgeries are being contemplated in order to prevent the morbidity and the mortality associated with the extensive surgery that were done previously. The transoral lasers are being used. Minimally access thyroid surgeries are also done. Nowadays, even microscopes and loops are being persistently used for the preservation of the structures that we are not intend to damage while doing the thyroid surgery. So these are the advances that are happening in the head neck region, and these are being incorporated so nicely and deeply with the younger generation that it has become a part of the surgery when they are doing the thyroid and the parathyroid surgeries. When we talk about head neck surgery, it generally, when stage 3 or 4, it generally is related with extensive excision of the mass together with the normal tissue as well, which creates a lot of defect. And that defect need to be repaired with plastic reconstruction, which at times need local flaps or at times require free flap as well. So again, this is an area where ENT is advancing quite nicely. We have ENT surgeons who are doing head neck surgery, not only the excision part, but even the reconstruction part. And when we talk about even further, then we are going toe-to-toe with the neurosurgeons as well. When it comes to about, when we talk about the excision of the pituitary tumors as well. We are doing it endoscopically with the SD cameras and the endoscopes with the nerve monitor, and we are doing it without any complications. So to sum up, like I'll try and ask few questions like what makes something best? Like, we can just take an example of like, do we know what is the fastest car in the world? So it's Koenigsegg Justo Absolute. It's one of these Swedish car which is thus fastest in the world. So that black car that we can see on the screen is the beauty or the beast, whatever you want to call it, but that's it. That's the fastest car in the world. It can churn out a speed of 531 kilometer per hour. It can do a speed of 0 to 60 in 2.3 seconds. That's fast, really fast. So what makes that car so fast? Is it just the engine? Is it just the make that is making it so fast? There are other car manufacturers are out there. So what makes it so fast? It's definitely not. It's not just the engine. It's the support staff that those people are having. Support staff in the form of people who are giving the inputs of how optimally the engine is going to work, at what RPM it's going to work, how to use it, and how to rev it in order to get the optimum output so that it can actually give you a speed of 531 kmph. Is that it? So the support staff and the machine, is that what it takes to get the fastest racing car on the road? No. You still are missing one integral part in this whole scenario. That is the driver, the racing driver, who will actually act as a link between the machine and the support staff, will utilize the inputs, and then finally will be actually putting the pedal on and putting the mark of 531 km/h on the speedometer. So these three things in unison actually makes what is the fastest car in the world. Now let's get back to ENT. Why actually use this example in order to understand what makes ENT right now one of the most sought after subject in the world? It is having a very cohesive and amalgamated unit, the ENT. We have already discussed about what scope it is having, what we can do with ENT, how many branches are there in the ENT, and how wonders we can do with the instruments that we have got. So we have the machine. We have the machine which can actually give you 1000 bhp power, and that is our subject. That's ENT. And what is the support stuff? Like we are already having a lot of instruments at our disposal. We have micro debrider, we have high-end microscope, we have HD cameras with endoscope, we have nerve monitor, we have Doppler, we have coablator, we have whatnot, we have everything. So that is the support stuff that we just talked about. So what's again the integral part in this? The tools and the subject is not complete without the surgeon. So here the integral part is the surgeon. So surgeon is the one who is going to unite this 10,000 bhp machine, that's ENT, with the tools that we are having. So a surgeon, ENT surgeon, should be cool and calculative, and meticulous and safe, and innovative, but unstoppable. That's what a ENT surgeon should be in order to achieve what's required out of this 10,000 bhp machine that we are having right now. And above all this also required a very good guidance and mentor, which we have in ample in our own fraternity. So we, as in our own fraternity, have everything mentioned here to take the shift to the next level. And the growth story of ENT is going to be nothing less than awe-inspiring in the coming decades, that I am for sure. Thank you.
Thank you, Rajiv. We actually sat together, the speakers, the panelists sat together to devise the session with the hope that it will be appreciated by the audience. We don't know if we have succeeded, but some input from the audience will be welcome, and also some opinion and some advices from the chairpersons. So we have 5 minutes time so that we can have some inputs from the audience. Ranjan, I think, Dr. Rajudri.
First of all, thank you. It's a very interesting concept to start the conference off with. Unfortunately, as with the opening session of any conference, you don't have the audience you deserve. But I think just a couple of points. I found it interesting about the subspeciality within a speciality. If you think about it, the first Negus textbook, which came out in 1909 or 1910, at that point you already had laryngologists and you had otologists. The concept of a unified subject of ENT came about 20 years or 30 years after. So it's as if we're going through full circle again. ENT as a combined subject wasn't what it started out as. You had general surgeons who were interested in different aspects of general surgery, and then it got to the stage where a man like Negus wrote a textbook, and if you look, his textbook was actually textbook of rhinology, and it was textbook of rhinology and laryngology, because at that point otology didn't exist, simply because all that you could do for an ear full of pus was drain it. It was only till antibiotics came that the establishment of otology as a separate specialty happened. So I think we're actually going through a circle. That's the first thing. The second thing is the NMC has been extremely active in bringing out new guidelines. We have this new undergraduate curriculum. But I think as an association, it is time we actually ask for more time. The amount of things that are expected to be taught to an undergraduate just in ENT is not something you can do in 3 months. Similarly, when the postgraduate curriculum comes out, if you want competency-based training and you want 3 months of a district referral program, 3 years is not enough to even learn the basics of ENT as a postgraduate specialty. I think increasingly we're looking at a system where we either have to go for 4 years minimum or even 5 or 6 years like in the West. And the second thing which wasn't brought out is, it's all very well saying that we need competency-based treatment. We don't have the faculty at present to do that. All of these are intensely faculty dependent. You have to have enough teachers and enough time for those teachers to do small group learning. For a few years, I was visiting in Malaysia, and the college I went to was doing problem-oriented learning, self-directed learning, all very well, but each small group required faculty to guide them. So there are lots of aspects to it rather than just saying. And last but not, I think Dr. Sharkar summed it up beautifully. And we shouldn't be so blinded by super specialities that we forget our basic knowledge. If you don't have the basic ENT practitioners, you're not going to get the patients who require super specialist training. But I think this was an excellent starter to the conference, and whoever thought this concept up, kudos to them. It's a good eye-opener.
Thank you, Dr. Aishodhari. Actually, ENT otorhinolaryngology is a product of the 20th century. And before that, it was only the otologists who were doing the surgeries, and the laryngologists were mostly physicians doing with the laryngology and the rhinology work. But they amalgamated, I think that amalgamation, that coming together, paved us the way for this great development. I think it is one of the fastest growing subjects in the medical fraternity. And yes, we have some difficulties regarding the number of teachers and the number of teaching hours. So we'll have to work it out. But we have a direction on which we should move forward. Our chairpersons, if they want to add something, for 2 minutes, sir. And before Dr. P.B. Rai speaks, I should also say a special thank you to Dr. Amitabh Rai Chaudhary, who actually gave some important inputs in devising this session. Dr. P.B. Rai, please.
Firstly, I'd like to offer my thanks to all the speakers and the way the conference has started. And regarding the subjects and the speakers, it was not in my knowledge that all these subjects could have been described, could have been spoken so beautifully, so that it could have been so much attractive. And particularly, I don't want to individualize the speakers. They all are nice in their speeches. But regarding Dr. Onimis, he has Onimis Ghosh, he has spoken nicely. And regarding the back to basics, in our time, as you have already said, that it is a very fast, expanding very fast. In our days, in Arjigor, there was no microscope. And we did have to depend on the basics. We regularly used to do indirect laryngoscopy. I don't know whether that has been done routinely nowadays, because with the advent of endoscope, laryngoscope, probably they are using it more. But then we used to use during the taking biopsy from the piriform fossa, the right angle, what is that name? Laryngeal forceps data. So all these things should be, I think, should have been kept in mind. And that's all that I can say, that the conference started nicely. Thank you.
So that brings us to the concluding part of the session. So Dr. Raju, do you want to add something to this session? So now I would request our chairpersons to hand over the mementos to our participants one by one. I would request the chairpersons to come in the center. They will first hand over the memento to Dr. Animesh Ghosh. Now, Monjula Devi will hand over the memento to Dr. Soikot Samadar. Soikot, please. Dr. Subhajit Banerjee to Dr. Rahul Sarkar. And all our chairpersons together will hand over the memento to Rajiv Singh. Now it is time for me to show my appreciation and regards to the chairpersons. I will hand over the mementos to the chairpersons.
Now I would like to request Dr. Shubhajit sir to felicitate Dr. Shomendra sir, our moderator for the session.